Hi, class. Chapter 16 is our last and final chapter of the book and, of course, of the class in lifespan developmental psychology. Of course, it makes sense, right? Death and dying is at the end, but I always joke that I should probably do my class in reverse because it is a little bit depressing to end on death and dying. However, here we are. It's something that we all must face. So let's go ahead and talk about these issues surrounding death and dying. Let's begin with ways in which death has been defined, end-of-life issues, and also patterns of mortality and death. So the chart here that's showing on this slide, the text is a bit small to see, so I'm actually just putting it there so that you know what to look for in your book. You can see it in the book in a much more clear format. This is showing overall mortality across all ages and how it declined about 60% between 1935 and 2010. The risk of dying has especially plummeted for infants and young children. There's been a 94% reduction in death rates for children ages 1 through 4. And this is likely due to better treatments, just merely the invention of or the discovery of antibiotics and appropriate treatments for conditions. Young infants are better able to survive conditions that they hadn't before. Mothers are also less likely to die in childbirth, and people are also more likely to survive conditions that were once fatal, again, like common infections that can be easily cured with antibiotics today. Now, again, the table on the slide shows leading causes of death by age. In infancy, the leading causes of death are genetically determined, prenatal issues and birth complications, as well as sudden infant death syndrome. In childhood, the most common causes of death are accidents, illnesses, and homicide. In adolescents and emerging adults, the common causes of death are accidents, drowning, unintentional poisoning like a drug overdose, illness, homicide, and suicide. In middle adulthood, you see some changes with the leading causes of death being cancer, heart disease, injury, suicide, and chronic illnesses. And in older adults, heart disease is the #1 killer, as well as other chronic illnesses. In addition, stroke and Alzheimer's disease. On this slide, we see the mortality rates of infant. Sorry about that. On this side, we show how the mortality rates on infants on the left and also death rates by age and sex on the right. And you see in general that the mortality rates of infants has shown an incredible decline over time. Just looking at 1940s, we see that deaths per 1,000 live births were at about 48 per 1,000 in infancy, and they've plummeted to about just 8 per 1,000 in infancy. So we've seen a really wonderful decline in deaths in the infant time period. And on the right-hand side, you see the charts looking at men and women over time. And again, we've seen this decline in mortality rates showing improved healthcare and the ability to cure many diseases. In regard to defining death, this is a really complex issue. The actual moment of death is not really easy to determine. We have one way of defining it called clinical death, and this is when a person's heart stops beating. They may be considered to be clinically dead. This is the cessation of cardiopulmonary functioning. And one issue here is that with today's medical practices, including widespread dissemination of CPR, we are now better able to regain a heartbeat. And so a person can be revived from what was clinical death. Their heart can stop, and then we can get their heart going again. So now a heartbeat is no longer a clear marker of life or, in its absence, death. Whole brain death is the irreversible loss of functioning in the entire brain. Death of the higher and lower brain regions, the cortex and the brainstem, without the possibility of resuscitation. And the criteria to diagnose whole brain death include no spontaneous movement in response to stimuli, no spontaneous respiration for at least an hour, a total lack of responsiveness to even the most painful stimuli, no eye movements, no blinking, no pupil responses, no postural activity, swallowing, yawning, vocalizing, no motor reflexes, a flat EEG for at least 10 minutes, and no change in any criteria when tested 24 hours later. So we would consider this to be the irreversible complete loss of brain functioning. Now, a bit of a gray area exists with what's called a persistent vegetative state. This is a state in which a person appears awake, but isn't actually aware due to permanent loss of all activity in the cortex. So they're not clinically dead. The deeper areas of their brain uh, uh, are alive, and so their heart is beating and they may be breathing, but they're not expected to regain consciousness or cognitive ability. The cortex of the brain is the part that's most vulnerable to conditions of anoxia, which is loss of oxygen, and therefore can be damaged first. So something like a heart attack, drowning, or traumatic injury can irreparably damage the cortex, while the brainstem may still be intact and functional, leading to a person who's not quite dead, but has lost many of those ways in which that makes them a fully functioning human. Uh, Persistent vegetative state patients retain an intact brainstem. Again, that permits heart rate, respiration, and also gastrointestinal activity. They're neither clinically dead nor do they meet the criteria for whole brain death. People in PVS have been the focus of several high-profile court cases, like the Terry Schiavo case. In this case, Terry Schiavo experienced extreme brain damage from cardio arrest. Her heart stopped due to complications from bulimia. And because of this, the cortex of her brain died, and she appeared conscious, but was not really aware or responsive. Now, her husband wanted to remove her feeding tube, whereas her parents did not, and really held on to the belief that perhaps she could be revived. And this led to a 7-year court battle in which eventually it was decided that they remove her feeding tube, but she remained in that persistent vegetative state during that whole time. So this brings us to the issue of end of life issues. When a person is near their end of life, uh, how do we make sure that their wishes are adhered to? So people desire a sense of control in what happens to them, especially in these decisions. Should a person be treated for an illness, or perhaps they would prefer to withhold treatment? They would rather die the next time that they have some type of an episode or a serious medical condition. Does someone want to go on a ventilator or not a ventilator? And what happens to their body after they die? So, dying with dignity is ending one's life in a way that is true to their preferences and controlling their end of life care. So, really important attention must be paid to a person's end of life issues when they are faced with their impending death. So the Patient Self-Determination Act also referred to as the PSA of 1990, guaranteed the right of all competent adults to have a say in decisions about their health care by putting their wishes regarding end of life and life-sustaining treatment in writing. And this is really important because many who are near death and are very ill aren't able to communicate what their wishes are. If they're on a ventilator, they can't talk, they can't say that they don't want to be on that ventilator. So this document ensures that their wishes are respected. There are a couple aspects of advanced directives. They include a living will and also a durable power of attorney. So this living will is that document that makes her wishes regarding medical care known. Do they want to be on a ventilator or not? And so they can identify what, if any, medical interventions should be used to prolong their life. Uh, and then a durable power of attorney, in which a person designates a trusted relative or friend to make these healthcare decisions for them. Euthanasia is the practice of assisting a terminally ill person in dying more quickly. And this is incredibly controversial because it, in a way, is very similar to suicide. And so obviously many people have some serious moral or religious issues with it. And also there are questions about if the person is making kind of a conscious, aware, appropriate decision about ending their own life. But courts have permitted euthanasia in hopeless cases where people are terminally ill and in great pain. Now, there are two different types of euthanasia: passive euthanasia, in which life-sustaining treatment is withheld or withdrawn, and this allows the person to die naturally. And most people do support this type of passive euthanasia, in which a feeding tube is removed or the air is removed. Active euthanasia is when death is deliberately induced. And so this could be administering a fatal dose of pain medication, giving so much pain medication that it ends up slowing their heart rate down to the point of death. And so that's taking more of an active role in leading to one's death. Physician-assisted suicide is a type of voluntary active euthanasia, and in this case, terminally ill patients make this conscious decision. They tell a physician that they want their life to end before dying becomes this kind of protracted, really painful, long, drawn-out process. Patients receive from the physician some medical tools to end their lives, and they self-administer this medication. Now, this has been controversial again because physicians take an oath to not hurt their patients, and some people see ending lives as hurting people, even when this is what the individual wishes. This is only legal in a few states in the United States, but we're seeing increased support for physician-assisted suicide over time, and you see this kind of ticking up in the more recent years in the chart, with now about 68% of people supporting physician-assisted suicide. Hospice is an approach of end-of-life care, and it's focusing on not treatment of the disease, not trying to cure a disease, but instead focusing on pain management and also attending to other aspects of a person's end-of-life needs, psychological, spiritual, and social support, giving an individual death with dignity and helping them prepare for it. The hospice philosophy, again, doesn't emphasize prolonging life, but just prolonging the quality of life. Palliative care is the focus on controlling pain and related symptoms, not trying to treat or attempt to cure the disease. So this would be, instead of giving chemo, which would be trying to treat the disease, instead it would be allowing the cancer to progress and the patient to eventually die, but giving them medications and care to help them manage their symptoms and their pain. In Western cultures, a mature understanding of death has the following components. First, non-functionality, the understanding that death entails the complete and final end of all life-defining abilities or functional capacities, internal and external, that are typically attributed to a living body. The body doesn't function anymore. Irreversibility, the understanding that the process involved in the transition from being alive to dead and the resulting state of being dead cannot be undone. Once a thing dies, its physical body can't be made alive again. And I share with you kind of a sad but a story that makes me chuckle of my nephew whose hamster died and they buried it in the backyard. And then my sister caught him the next day trying to dig him back up and save him, not understanding that once he was dead forever. Kind of sad. 3 is inevitability, the understanding that death is universal and all living things will someday die. And then 4 is biological causality, that death is caused by events or conditions that trigger natural processes within the organism, that it's not caused by bad behavior or wishes, that it's a biological thing. Children don't understand loss and death in the same way as adults, but they often have a more mature understanding of these events as adults may expect. So they encounter death in many ways, and you can think about how you may have already encountered death even as a young child or maybe as an adolescent. Grandparents, parents, other important adults, siblings, and friends may die. Most children experience the death of a pet as a very significant experience. They might overhear adults talking about death. In TV, they talk about death. It could be a theme in TV shows. There are death themes in children's play, in rhymes, and songs, and fairy tales. They encounter death in different ways in their lives. Children between ages 3 and 5 tend to view death as temporary and reversible. Between ages 5 and 7, they begin to understand that death is final, irreversible, and inevitable. And this corresponds to transitions from pre-operational reasoning to concrete operational reasoning from Piaget's stages. Late childhood is when the understanding of biological causality of death emerges and is usually mastered at about age 10. And different contexts may expose children to more or less death. If a child is growing up in war-torn or poverty-stricken nations, they're more likely to experience tragedy and death in their families, as opposed to those who are in more privileged areas and perhaps protected even from the deaths around them. Also, how parents talk to their children about death and whether they talk about how and whether or not they even talk about death influences children's understanding. In terms of adolescence, they tend to describe death as enduring, as also an abstract state of nothingness, this inevitable, irreversible end of everything biological. Now, remember, adolescents have a personal fable. They view themselves as unique and invulnerable to their consequences of all of their risky behaviors. And this includes death. They think that I can go out and drive my car fast without my seatbelt on. Nothing bad is going to happen to me. It happens to other people. They don't think that it will actually apply to them. And this risk-taking behavior is characteristic of adolescence and is a form of cheating death, an event that is perceived as distant, but a very unlikely possibility currently. Adolescents often hold a belief in an afterlife, whether religious or supernatural in origin. They are able to kind of simultaneously hold this mature biological understanding that death is the end of body functions, but also have cultural and religious beliefs about an afterlife at the same time. Young adults begin to acknowledge that they have vulnerability. Their personal fable declines. They also see a decline in risky behavior, that death is something that can happen to them. And part of this is because of this awareness that they aren't invulnerable, and they start to experience kind of the deaths of others as well. You see this awareness of death increasing in middle adulthood as they gain experience through the death of parents, friends, siblings, and colleagues. This awareness often causes those in middle adulthood to reevaluate their priorities, often leading them to pursue a sense of generativity, the sense of giving to others and contributing to future generations, or contributing to a bit of a legacy, because they realize that they will not persist forever. Older adults are also likely to have exposure to death many times. They may become socialized to the nature and inevitability of death and gain more of an acceptance of death. They may think, when it's your turn, it's just your turn. Now, research also suggests that death anxiety tends to decrease over the lifespan. So even though older adults are kind of closer to death in a way, they are less anxious about it, are more accepting of it, and just see it as something that is going to happen eventually. People experience dying in many ways, including the trajectory at which the dying takes place. This dying trajectory includes the rate of decline that people show prior to death. This varies by duration and also descent, and it's categorized into 4 patterns. The first one is this abrupt surprise death, sudden, unexpected, and instantaneous, such as an accident, a shooting, or a heart attack out of nowhere. Also, the second is short-term expected death. This is a steady, predictable decline due to a terminal illness, such as cancer. The third is an expected but lingering death. This is anticipated but prolonged, so it takes a long time, even though it is understood that it is happening soon, and this is related to like frailty or old age. And the last one is re-entry death, in which a person shows slow declines punctuated by a series of crises and partial recoveries. So the dying person may have repeated hospital stays, but then return home between stays, and then perhaps go back to the hospital and then come back home over and over. Short-term expected deaths, like sudden stage 4 cancer, are more likely to be in hospice. Prolonged trajectories, like the expected lingering death and reentry deaths, are more taxing on caregivers, and the person may not be in hospice until it is absolutely clear that the death will happen soon. On the right-hand side, you see graphs of these different dying trajectories. Now, there are predictable changes and symptoms in the dying person in the hours and days before death. These include loss of appetite, weight loss, loss of muscle mass, disorientation, poorer vision, visual and auditory hallucinations, decline in cognitive functions, pain, shortness of breath, irregular breathing, nausea, disrupted bladder and bowel function, lethargy, and also what's called the death rattle. Breathing becomes noisy and has something like a gurgling or a crackling sound along with each breath. Kubler-Ross categorized people's reactions to death into 5 types or 5 stages. So she interviewed people who were facing death and identified these different ways or different experiences that they were having. The first being denial. They don't believe in the diagnosis. They deny it's true. They seek a second or third opinion and just don't think that they could possibly be facing their own death. Then they may face anger, like, why me? And they might feel cheated or robbed of life. And they may harbor resentment. They feel that it's unfair for others to live while they must die. Then bargaining. They bargain in order to find a way out. Perhaps they try to strike a deal with God or with fate. And they think things like, could I just leave? Could I just live long enough to see my daughter get married? Then depression, knowing it is the end, brings profound sadness and grief, knowing that they have to part with their future, part with relationships, and leave this life and not return. The last is acceptance. They no longer fight death, and they accept it as inevitable. They may seem at peace and begin to detach from the world. Now, she describes these as a series of stages, but not everyone experiences all of them or even proceeds in the same pace or in the same order. And also, it tends to ignore the relevance of context. Dying is an individual experience. People have different relationships. The illnesses are different family support and situational factors. And so dying, it can be incredibly different from one person to the next. When a child is dying, physicians and parents often have a difficult time talking to children about their prognosis and about their impending death. And as a result, children are less likely to develop this clear understanding of their condition and that their death is imminent. However, they often show a maturity beyond their years. They often have a more mature understanding of death than would be expected at their age. So they may know death is final and irreversible before others of their own age. And despite parents and doctors kind of protecting them from this idea of them dying, they tend to pick up on it and think about it and are more aware of it than parents think they are. Death should be discussed with the child using concrete terms and at the child's developmental level. What is appropriate for them using their vocabulary that they understand. Parents and loved ones are also advised to stay with the child and read, sing, hold their hands, sleep with them and cuddle with them, and that can help them during that difficult time. When adolescents are facing their own death, they tend to have a more mature concept of death compared to children. They may feel that they have a right to know about their illness and prognosis, and this reflects their autonomy, their independence. Their sense of invulnerability may lead some of them to actually deny their illness and try to reject treatment. Again, this is related to that personal fable that death couldn't possibly be happening to them, that they're invulnerable. And so they may refuse treatment that is really important to them. The side effects of treatment, like if they're experiencing hair loss or weight gain or weight loss, can harm their self-esteem. Adolescents are a bit more fragile when it comes to their self-image. And they often focus on the social implications of their loss because peer relationships are more important to adolescents. They want to be going and hanging out with their friends and having a normal social life. And if they're kind of stuck in this hospital, then this really has a much more harmful effect on them. They take it harder, the fact that they're missing out on these social aspects. Now, adolescents who are realizing that they're facing their own death may feel angry and cheated, and they have to they're losing out on this future that they thought that they had. They aren't going to grow old, and they may not get married, and so this can be really difficult for adolescents. It can help them to find meaning and purpose both in their lives and in their deaths. For young adults, they also often feel that they're cheated and that the world is unfair. A terminal illness may pose challenges to satisfying intimacy needs. It's difficult to form close and secure relationships when one is ill and has limited time left to live. So a person may develop a relationship with someone but not want to commit, not want to get too close because they realize that they aren't going to have the lifespan to share their life with that person. They also lose the sense of an unlimited future and feel as though their future is limited and their days are numbered. In midlife, adults tend to mourn the present. They worry about abandoning their current family and about not having completed their journey. For older adults, they come to have a sense of integrity after a successful life review. They're more likely than younger people to accept death, to feel that it is appropriate, and to be free of any sense of unfinished business. Now, in terms of dealing with the loss of someone else, so as opposed to your own death, instead dealing with someone else's death, a few key terms we have here. First, bereavement. This is a state of loss brought on by the death of a loved one. So to be in bereavement is what we say. Grief is what someone would be experiencing. So an emotional response, feeling grief. So a response to a loss, including complex emotions. It can be hurt and anger, guilt and confusion. It's not just sadness. It can be a whole bunch of feelings. And then mourning. This is the culturally patterned ritualistic ways that we express bereavement. So gathering together in a funeral, saying prayers, wearing special clothing like wearing black, all of that is involved in being in a period of mourning. People vary in how intense they react to loss and also the timing of those reactions. There's really not one correct way to grieve. Some people have very intense reactions and are gone from work and their relationships for quite some time. Other people return to work and their relationships the very next day and seem to not really go through that very strong grieving process. And that doesn't mean that they're cold-hearted. People just experience grief differently. The emotions can include anger, anxiety, loneliness, guilt, helplessness, and sometimes even relief once a person who has been suffering passes on. The physical sensations include tightness in your chest, feeling out of breath, stomach pains, and weakness. And the behaviors may include just looking for that person, being kind of absent-minded, having a hard time sleeping, avoiding reminders of the deceased person, and also a loss of interest in activities that they used to be interested in. Grief is this active coping process. The person has to come to terms with their changed world, that they've lost this person, that there's almost like a piece of them missing, that it affects their physical world, their interpersonal relationships, their routines, their sense of self. When a woman loses her husband, she loses this role of wife, and it can be incredibly life-shattering to deal with. Some have suggested that there are stages of grieving similar to Kubler-Ross's stages. Several phases of mourning, from shock, just being shocked and kind of feeling a bit numb to everything, to intense grieving, to establishing a sense of balance, and then accommodating the loss to one's sense of being, so adjusting to the loss of that person. Others view mourning as a set of tasks to accomplish. They must accept the reality of the loss and experience pain or grief, adjust to life without this deceased person anymore, and develop a new life while maintaining and enduring a connection to that deceased person, not just pretending that they never existed, but maintaining a connection even beyond their death. The dual process model suggests that bereavement is accompanied by two types of stressors: loss-oriented stressors and restoration-oriented stressors. So when a person focuses on loss-oriented stressors, they're focusing on the emotional aspects of grief that accompany the loss of an attachment figure. So managing emotions and breaking ties to the deceased. When they focus on restoration-oriented stressors, this involves focusing on the life changes that accompany death, moving to a new residence, the social isolation, establishing new roles, managing practical details, completing paperwork. It reminds me of how my grandmother, after my grandpa passed away, she had to learn to pump her own gas. He had always done it for her entire life. So in her 80s, she had to learn how to pump her own gas and write checks and do all of these things that he used to take care of. Now, healthy adjustment is promoted by alternating focus between these two types, sometimes focusing on the emotional aspects, sometimes focusing on those life changes, but adapting to the loss of that person. Deaths are interpreted and grieved differently based on several factors. So how old someone is when they died. We tend to grieve more intensely when a young person dies. It's seen not only as a loss of that person, but a loss of their future as well. The nature of their death, So sudden and expected deaths are more challenging. There's really no time to prepare or to say goodbye or to mend the relationship before the person leaves. Uh, and we may experience what's called anticipatory grief. So this is grief that occurs before the death actually happens, a feeling of loss. So imagine that there is a couple where one person has a terminal illness that is kind of a long, drawn-out death. These losses happen well before the person actually dies. There is perhaps a loss in intimacy, a loss in the being able to help out around the house and help raise the children, a loss in more of that conversation if they're losing their ability to communicate. So people grieve losses as they happen. Each loss generates its own grief reaction and mourning process. So even with the opportunity to prepare for a loss, it can still be very distressing for individuals with this anticipatory grief. Losing a spouse leads to widowhood. So widowhood is the status of a person who has lost a spouse through death and has not remarried. Losing a spouse begins one of the most stressful transitions in life. They lose the person that is closest of them, and they again have to renegotiate their sense of identity, that they're used to taking care of this person. This is my husband, and I am his wife, and so they lose that role and that sense of self. Loneliness is one of the biggest challenges of widowhood, and even though widows often maintain and even increase social participation following spousal loss, they may become more involved with family members like kids and siblings. This may decrease after a few years, and again, the loneliness can kind of creep in. Now, interestingly, the widowhood effect is the increased likelihood for a recently widowed person to die. And this is just one strong example of the relationship between social relations and health. And this is found across all the world. If one person dies, the other person is at an increased risk of dying shortly after. Losing a spouse poses risks to mental and physical health. So greater risk of depression, suicide, dementia, mortality, poor cognitive performance, and anxiety. Men tend to show more health problems, including higher rates of dementia and mortality, depression. Men also suffer more from losing social relationships. And this is because women tend to be the social glue that hold men together with their families and sometimes even with friendships. And men also have difficulty asking for assistance when they need it. Now, resilience in widows and widowers depends on many factors, like the circumstances surrounding the spouse's death and also their age, as well as personal characteristics. If they're outgoing, have high self-esteem, and high self-efficacy, then they fare best after losing their spouse. Now, losing a child is really the most difficult death to grieve. It kind of violates this perceived order of natural life, that it's supposed to be that the parents die first and then the child outlives the parent and then dies. So this compromises the continuity of the family life cycle. The loss of a child entails a loss of the self and the loss of the hopes and dreams for that child and of the future. So you're not just losing the person, you're losing the future relationship that you expected with that person, but then also the future that you expected for that child even after the parent dies away. The age of the child has little effect on the severity or grief of dealing with the death of that child. Old or young, it's very difficult for parents. Guilt is a really common response. Many parents question their adequacy in providing care, especially if the death resulted from a preventable accident or when the cause of death is not understood. Bereaved parents may tend to experience grief over a longer period of time than other bereaved people. They spend a longer time dealing with this grief than people who lose other family members or friends. And for many, mourning is a lifelong event when a person loses a child. For losing a parent, this is a loss of a lifelong relationship. This is someone that you have known usually since birth. This is often a very strong attachment with many shared experiences. This is a person who shares a great overlap in your life often. Adult children may also have reorganized their lives to care for dying parents, and the loss of the parent can cause further household upheaval as the adult child needs to refocus his or her time, effort, and attention. Death of a parent influences adults' sense of self and enhances the feelings of mortality, as the loss of parents marks adult children as now the oldest generation. And this is something that many people who lose parents start to feel. It's like they've lost their safety net in a way, but then also now they are the oldest generation. So they feel like they have kind of come to a different place in life than before when their parents were alive. It also influences sibling relationships. They must reevaluate the meaning of family and their roles without without the grounding roles of parents. Do siblings maintain their relationships together, or do they drift apart? When children experience the death of a loved one, it's influenced by the deceased person's role in their life. Children are more affected if they are close to this person. So think about grandparents who live close by versus grandparents who are far away, who they don't see very often. Children are more affected by the death of the grandparent if they live close by. It's also affected by the child's developmental level and also the understanding of the nature of death. It's important to note that children worry about who will take care of them. Death makes them think about the loss of their parents, especially, of course, if it is a loss of a parent, and they worry that they'll just be out on the streets with no one to take care of them. So they may need reassurance that someone will always be there for them. They may grieve for their parents for a longer period of time than adults do, and may strive to maintain a connection with deceased parents by talking to them, dreaming about them, and holding on to symbolic objects that help them feel connected to them. Bereaved children need support, nurturance, and continuity in their lives. So it's important that other adults step in and fill that role for those kids. And just the last bit, a bereavement in adolescence. Following the loss of a parent, adolescents tend to feel really isolated and lost. They feel that this is a loss that can't be overcome, and they often feel this sense of unfairness and anger because this happened to them, that they should have a parent for much longer than they actually did. Adolescents are more at risk for social and interpersonal difficulties, anxiety, and depression. And their experience of grief is influenced by their ability to understand and manage their emotions. So the personal fable may make them believe that their grief is unique and incomprehensible, that no one could possibly understand what they're going through. Grief can also interfere with normative processes in adolescence. This need to gain autonomy and form intimate relationships, so grief can sometimes get in the way of those processes. Grieving adolescents commonly worry that they'll forget the person that they've lost. Adults should attend to those feelings that underlie what the adolescent is saying and help the adolescent understand that their feelings are important and real and normal. Adults can help find ways to remember the deceased person and make meaningful connections that help the adolescent retain their attachment with that deceased loved one. So thank you all for listening. I know that was sometimes a bit of a difficult lecture and difficult topics to hear about because many of you, including myself, have lost some important people as well as pets in our lives. So wish you all the best, and hope that you can talk to others and seek out that social support and that help that will help you adjust to that difficulty.